Okay, great. Well, so here we go. Hello, my name is Siddharth Tambar. This is the Regenerative Medicine Report. I am super, super excited with who I have as a guest today. This is our first Facebook Live attempt to do this. My guest today is an orthopedic surgeon at the Sports Medicine Clinic of North Texas. He's the founder of the Dallas PRP and Stem Cell Institute, founder of the Las Vegas Orthobiologic and MSK ultrasound course. He's one of the founding editors of the Biologic Orthopedic Journal. And oh, by the way, he was also a Division I athlete at Stanford and happened to have played pro baseball for the Baltimore Orioles organization. Welcome, Dr. Don Buford.
Thank you very much, Siddharth. I appreciate the invitation to spend some time with you.
Absolutely. I love the fact that the last thing I closed with was, oh, by the way, you happen to be a professional baseball player before you became a sort of trailblazing physician. You sort of entered my orbit back in 2009. That's when I first sort of recognized, okay, here's a interesting guy, Dr. Buford. I had gotten interested in musculoskeletal ultrasound back in 2007. And at that time, there was almost nobody who was interested in this for an MSK reason. And I really got interested in it. I got really obsessed with trying to learn how to do shoulder ultrasound, diagnostic, and interventional. And so I think you started your ultrasound course back in 2009, and you held one of your courses in Chicago. And what stood out to me was, as someone who'd had some experience, I was really impressed at, number one, the high quality of what you were presenting. Number two, just the high level that you were really teaching shoulder ultrasound, to the point where I looked around at some of the other attendees who were complete novices. And I almost felt like shaking them, saying like, I don't know if you really realize what you're getting here, but this is as good as it gets. And I think what you were teaching 10 years ago has actually stood the test of time and is still probably 95% of what you can really see on shoulder ultrasound. You were teaching that back then as you are now. How did you even get involved in MSK ultrasound at that point?
It's an interesting story. Like a lot of things that I've ended up involved in or interested in, it wasn't the original plan. And what happened was I was actually overseas in Europe at an orthopedic course, sports medicine course. And I was one of the faculty on schedule to do some live surgery. And they had a couple rotator cuff patients set for me to operate on the next day. And I said, okay, great, let's go make rounds, see the patients, at least introduce myself. Let me see the MRI scans. And they all said, no, there's no MRI scans. We only have ultrasound. And I had no idea, at that point, I had no idea what that meant. So, I had no training in ultrasound in residency or fellowship. So we saw the ultrasounds, and their registrars and consultants were showing me the tear and showing how to measure and showing why it was a tear on ultrasound. I thought, this is really cool. And of course, you get in there at the time of surgery and get the cases done. But what I brought home with me from that course was ultrasound is something that was used at that time so much more overseas, where they didn't have access to MRI on every corner or in every strip mall or every office. But ultrasound was more readily available. So I came back here and within about 6 months, I hooked up with another like-minded orthopedic surgeon. And about a year later, we started the course that you came to, which was, like you said, the first year that we did the course. So for me, it was a natural outgrowth of just being curious about things and kind of picking up on how useful it would be to have this kind of same-day answer to a lot of our clinical questions right there in the office.
Incredible. That makes so much sense. In your professional career, you strike me as someone who's made a lot of smart decisions in terms of how you've grown, whether it's literally starting in something totally different as a professional athlete. And yet, as that came to a natural conclusion, you'd shifted into medicine, into medical school. You then shifted into a traditional orthopedic surgery. You then started in orthopedic practice, became well known as a sports surgeon in arthroscopy, and then incorporated MSK ultrasound. You then incorporated the orthobiologics as time went on. You've incorporated social media. That speaks really well to somebody that even if they're really good at one thing, they're still adding on the next thing. Is that something that you have purposely done? Is that something that's just sort of accidentally happened just by good fate? Or is that sort of how you really pursued your career as a professional all along?
I've really, I guess I was fortunate in my early kind of formative years to have some mentors that were trailblazers and were curious, thoughtful, engineer minded, just outside the box thinkers. And that didn't, that couldn't help but rub off on me. And so, growing up, I had an interest in athletics, as you mentioned, and I didn't want, I was going to chase that until they told me to get off the field, which is what I did, and had an interest in sports medicine and orthopedics from basically my junior, senior year of high school is when I did my first kind of externship at an actual orthopedic clinic. So I always had those two interests. And then within my practice career, um, I like staying engaged. I like a challenge. I don't just want to go to work and do the same thing every time, even though, most of my practice has been around the shoulder and knee and sports medicine. But now with orthobiologics, what's been really great about this is that it's really opened up orthopedics to me back right. I'm seeing every joint and doing things that I wasn't doing for the last 15 to 20 years, where I was really focusing my surgical practice on shoulder and knee. So as a regenerative medicine doctor, I'm now seeing people. I just got off the phone from a patient who has plantar fasciitis who wants to come in. So that would have been something I would have never seen as just a shoulder and knee specialist. So I just like being engaged. Obviously, I like helping people and trying to keep people at their top functional level with as minimal, involvement and surgical exposure as possible. So orthobiologics made perfect sense. So for me, it's just kind of a curious mind and growing up in an interesting time as you have, where so many things are cutting edge, but yet there's enough established science and data that we can incorporate it clinically.
Yeah, I sometimes jokingly say that in my own career, I've just sort of stumbled into things based on just interest level. I frequently like to think that I'm very sort of good in terms of top-down thinking strategically, and yet in my life, all the best decisions I've ever made were totally just gut instincts, what seemed to make sense at the moment, what seemed interesting. Ultrasound was just a complete lark, something to learn. And then as I got into that, just realizing how dynamic the MSK system is and the layers and the depth to everything, which then naturally leads you to say, well, what else can we do that's better than what we're already offering? And just going down the rabbit hole, which is, I think, really the right way to kind of pursue your profession. But when you talk to a young physician who's starting to get involved in this kind of field, it's not always the most helpful because they seem to come out of training now fully sort of trained with the best sort of technical skills, but they don't have a lot of the other stuff. I sometimes feel like I'm an old man, even though I'm not that old. But when you meet these guys who've got everything technically related, they don't have necessarily the experience, the judgment, or sort of the perspective as to why to do things. But it's sometimes hard to tell them, yeah, pursue your career like an amoeba. Just keep on reaching toward what is the next interesting thing. But sometimes that works out better.
Well, and I think there's a lot to be said for experience. And even now, 20 years in, I mean, we see each other at all these meetings. We're always students of the game, if you will. We're always students of science and of medicine. And, whether it's surgery or regenerative medicine, I think half of the battle for us is knowing when not to intervene, knowing the natural course of some of these processes, some of these injuries. And as a surgeon, it's important. It's as important for me to tell someone you don't need surgery for this as it is to say, yeah, here's surgery.
Right, Don. It looks like we yeah. It looks like we cut out for a second, but I totally agree with you. So describe to me how along that journey, how did you end up incorporating orthobiologics originally, surgically, non-surgically? How did you originally get involved? How has that grown over time? And how has that developed in your practice?
Yeah, my initial involvement was with some exposure to platelet-rich plasma. And this is we'll call it about 9-10 years ago, I think it was. No, it was a little bit longer than that. And there were some papers just coming into the orthopedic literature using PRP kind of as a surgical addition to try and speed up healing. It was really at the time centered around rotator cuff surgery, which was in my wheelhouse, and so I was keeping up with all that literature at the time. And I thought that would be something that would be interesting to study, because I still, even to this day, still feel that that's one of the weak spots in our surgical outcomes is we can't affect the biology. Now we can, and we're moving in that direction. But especially a decade ago, that was something that I think was just sitting there waiting for us to figure out a way to help. Trying to increase blood supply, increase stem cell involvement, or whatever paracrine activity, whatever it took to get something to heal better than just a 70-30% chance. And so my first two studies were with PRP and with rotator cuff related issues, one surgical, one non-surgical. And both of those studies didn't give me the result that I wanted in my hypothesis, which made me even more curious. And so that was really the hook, line, and sinker for me, because I could tell that it was making a difference, but it didn't quite give me the same outcome as I was expecting. And so then it became, how do we get a dose response curve? How do we figure out which formula is the right formula? There's so many questions in this field, as you know, that we can both spend the rest of our practice lives thinking up really cool studies. I've got a chalkboard at the office that's got 10 ideas on it already that, if I had a huge department, we could start knocking these things out. But
yeah, it's interesting when you think about the right way to pursue something. The colleagues that I am sort of most excited to talk to, listen to, respect the most, they get involved in the minutia to a level where if you're just sort of a generalist, you're hitting 10 different things, it doesn't make sense. But the folks who get obsessed about things like, what dose of platelets to use, should you use BMAC in this case, should you use no red blood cells or with red blood cells, that's what moves all these kind of fields forward. So based on that initial experience with PRP, how are you using some of the orthobiologics, let's say during surgery, post-surgery, or even pre-surgery? How are you involving that in your surgical practice?
So in the surgical practice, I really try and stay where a couple things have to combine. One is I want to have some pretty solid data that it is going to make a clinical difference, because these things still aren't free, even in surgery. They're not covered procedures. So great example today, I had two cases. The second case was one of my younger patients who had a meniscal tear, and we repaired her lateral meniscal. It was actually a bucket handle meniscal tear, relatively uncommon and kind of difficult to repair because of its anatomy, and she had a small, and a small knee. But there is pretty good data that using BMAC or BMC kind of at the meniscocapsular junction can increase the healing rate of these bucket handle tears. And so this was an example where just injecting her in the office, I didn't think I could keep that meniscus reduced, because there would be nothing holding it up against the wall of the capsule where it needs to be. And so I thought there was a surgical indication, and yet the surgical result was really only about 60-40. If you go out 3 to 5 years, something's going to happen. You may not get the long-term result that you want. And there's a couple studies that showed that using an orthobiologic that was autologous that we did in the operating room before doing the actual surgical procedure can almost add 30 or 40% to the success rate, basically. So that's what we presented to the family. I see my role in those situations as kind of an educator, where I lay out the data to the family. We actually look at papers together in the office if they're so inclined, or I can summarize it for them. And then at the end of the day, I say, here's what we have as options, A, B, C, D. I can do all these different things. What makes sense for you? And if you have more questions after you chew on it, let's talk about it some more. So they decided to do the BMAC today and came up to Dallas to get it done. I've had other patients in the same situation say, we'll sit tight and see how it goes. And I don't fault them for making that decision 1 minute. I just want to make sure they have the data so they don't go back, or they don't look back and say, gosh, I wish I had known that. We would have done that.
Yeah. I think that's the big thing, sort of being upfront about what is the science, the data, what is actually proven, what makes sense. So much of this is on the margins in terms of where's the evidence and all that, and trying to use good sort of clinical sense with what's actually been proven, what's your own experience, what's colleagues' experiences. And I always say, what would you do for your own sort of family member? That's always sort of the clinching thing, I think, in the end. And combining all that, I think adds so much value to patients, that kind of experience. When you talk to your own orthopedic colleagues, You have such a unique skill set because you have that really strong traditional orthopedic background, you have the strong ultrasound background, and you have the strong orthobiologic background as well now, and the experience with that. How do you introduce this to your own colleagues? How do you encourage them to get involved? Because you're clearly a unicorn in this field. And how do you really encourage them to get involved at this stage?
It's interesting. It's something I actually, I don't want to say struggle, but I work with at virtually every meeting I'm asked to attend. And I go to, 9 to 12 meetings a year, and I lecture at virtually all of them. And at every meeting now, and at every orthopedic meeting, there's talks about orthobiologics. At the recently concluded sports medicine meeting, there was like a whole day just on orthobiologics. So it's amazing. There's more and more people with more and more data. So it's not seen as out there in left field as much as it used to be. But for people wanting to do this in their practice, like anything new, they're having to wrap their head around how is this going to affect my clinic. For a lot of my colleagues, having a cash pay procedure is totally foreign to them. None of us have really had concierge type practices in orthopedic surgery. In fact, half of us now are employed by hospital facilities and may have to really think about how we can do a cash pay procedure in that environment. So for most people, though, I tell them start with where there's the most data. If you see knee patients, we all see knee patients that are 35 to 55 or 60 that have varying grades of arthritis, and we don't want to put steroid in. Luckily, most of my colleagues believe that data now. We don't want to rush them off to arthroscopy for a degenerative meniscal tear. Most of my colleagues know and believe in that data. And so what do? You can try some of the viscosupplementation, but the head-to-head randomized controlled trial data shows PRP is better. So if people are really hammering on we need data, then fine. Here's the 3 or 4 areas where we have it around the elbow and the spine and the knee for people that are comfortable with case controls and have an experience level where they know that the alternative could use some, has room to improve. Then we can go to that next step and use it for more areas like plantar fascia and around some ligament and tendinopathies. But it's a struggle with anything new, especially when it requires a new financial piece at the moment. I think it makes it a little more difficult to incorporate. It's the same issue you have with ultrasound and still do, trying to get people to see the value of ultrasound is not difficult, but to actually make the purchase and incorporate it into their daily clinic, you have to have a mindset where you commit to it.
Right. Absolutely. It requires more than just an intellectual commitment. It really takes a commitment to change how you're even practicing, which is interesting. So you are one of the founding editors of the Biologic Orthopedic Journal. I think it's you, Dr. Mishra, Dr. Morel. How do you see that? How do you see the purpose of that? How do you see that growing? How do you see that leading sort of the way forward for orthobiologics? What's sort of the vision behind that?
We are really excited about this. And we just had our first issue come out. We're publishing the abstracts from Toby and I think from the Indian Regenerative Medicine Society coming up. But our goal with that is to have kind of one journal that all of us think about when it's time to publish something clinical or even basic science or even a bench study. But if it involves notice it's orthobiologics. So we're not talking about some of the other things that you see advertised on the internet. But in terms of orthobiologics, right now, to find the literature, it could be in a orthopedic journal, it could be in JBJS, it could be in pain medicine journal, it could be in a radiology journal. There's lots of different places. And it actually, for guys like us that may have filters that give us a message every day, if there's a new article that meets our subject criteria, it's still daunting to go through all those different sources and to have hard is to have an open access journal that's available on the internet that has rolling publication. So if you or I have a paper to submit, you don't have to wait 3 months for the next issue. Once it goes through the review process, it can get published online right away. So I think that's a real attraction for authors also to know their data and their hard work's going to get out there. And the fact that it's open access and free means you don't have to worry about a $600 to $800 subscription annually. So that part is subsidized, and the authors still maintain ownership of their work. So we think that we're ticking all the boxes that we would want personally to have our research presented. So I'm hoping to garner a lot of support amongst our LinkedIn colleagues, our IOF colleagues, our Regenx colleagues, all the different major players in this field. I think it's a good source to think about when you have something that you want to share with the rest of us.
I think the three founding editors, I think that goes a long way to it as well. Three guys who are really, really well respected at the forefront of this field, who've been really well experienced and involved for over a decade now. I think that makes a huge difference. I think leading in that regard is so smart, and hats off to you guys for doing that. That's a ton of work, but obviously it's sort of helping to lay the building blocks for the next 30 years, the next few generations of physicians who come in that can say, here's how we've built forward. So I think that's fantastic.
And I will say one other quick thing. We're just three guys, and the response has been overwhelming. Anybody you can think of that you've ever met at a meeting that's interested has been invited to be either on the review board or to be a section editor, yourself included, and the response has been tremendous. I can't think of anybody that I've met in the last 10 years that's remained interested in going to academic meetings and interested in research that hasn't wanted to be part of this. So we're very, very grateful for the response today.
So on a slightly different level, we know there are a lot of challenges with the field now as well. This is not to be too negative, but it's good to sort of recognize what are some of the bigger challenges and then recognize them as opportunities as well to sort of grow and get better. From your perspective, what do you see as the 2-3 sort of biggest challenges right now to helping this field grow in terms of legitimacy and adding value to patients?
I think we're getting closer. It's an ongoing struggle. Every week, probably a lot like you and other colleagues of ours, I get 3 or 4 invitations to make online purchases of products that I know are not registered and regulated correctly. And as a clinician, that's one thing. When it filters down to direct to public advertising with websites where things are listed, where at least in the United States, that really you're not supposed to be doing those sorts of things. I think that's a struggle. And what happens, or what the risk is a lot like what happened in Canada recently, where Canada said no more stem cells. We don't care where it comes from. We're going to take a hard stop and regroup. And I think that's a mistake. I think that pendulum has swung way too far the other direction. I'd like to see a situation where, as long as we're using and abiding by published FDA guidelines, that we're okay to continue doing these procedures clinically, because the claim that there's no evidence just frankly isn't true for so many different areas in orthopedics. If the FDA wants to state that certain uses are more dangerous than others, like into the eye or IV or intrathecal, and wants to regulate those more strongly, then I'm all for it. But I think the risk that we have on that aspect as clinicians is being lumped in as a stem cell clinic. That seems to be the hot item. That's what the newscasts and the reporters and journalists love to latch onto, is that so-and-so stem cell clinic was shut down again. And I don't market that way. I'm an orthopedic surgeon. I'm an orthopedic clinician like you are. And the fact that we do different regenerative medicine procedures doesn't make us a stem cell clinic. It just means that we're using orthobiologics in a thoughtful way. So I think that's one. I would love to see some coverage for these procedures, because I think people in the business know that we're saving society, or saving people, or saving employers lots of money by getting people back to work and keeping them at health longer. And if not eliminating completely some of these more invasive orthopedic procedures, we're significantly delaying them. And the cost of 1, 2, or 3 PRP injections, or even 1 or 2 bone marrow derived stem cell injections, is far, far less than almost any surgical procedure. I think just getting into the OR to do a knee arthroscopy is going to cost a sum total of about 10 grand, even at a relatively cheap facility. By the time you pay the doctor, anesthesia, and the facility fee, and whatever other instrumentation. So, that's more than virtually all of us charge for stem cells or PRP. And so I think down the road, if we can convince Medicare that we can save them money by treating that population, that will be a big push towards getting all of the insurance companies to cover it. And I think that'll expand access, give us quicker data, quicker results, and allow us to grow even faster than we are now. Right now, the public demands it. The public is very interested in this as a treatment option. And I'm sure you see the same thing in Chicago. They want to not be lied to, and they want somebody who's skilled and who's thoughtful, and they want somebody who is willing to do these procedures for them and doesn't just have a surgical answer every time the MRI scan shows something might not be exactly normal.
Yeah, that makes so much sense. I think some of the I think there's a big problem right now that we have in healthcare, which is that the general public genuinely has trust issues with healthcare. And a lot of that is because of how it's structured and a lot of the middlemen and all that. And I think it's contingent on physicians that we have to continue to lead. We have to actually start leading more. I think it's actually pretty straightforward and relatively easy to have trust with an individual who's sitting in your office. They've already, you have that immediate contact. I think it's so important, though, for physicians who are actively involved in patient care to be out there really speaking their truth, what's legit, what's not legit, because we have to lead in that way. In that respect, you're another really interesting thing you've done is you are really pretty actively involved in social media, whether it's at a pretty early stage, putting out YouTube videos of procedures that you've done. I mean, that's amazing. I don't actually know too many orthopedic surgeons that do that. I mean, that was pretty cutting edge. Or your involvement in LinkedIn with other professionals, really leading in that respect as well. And yet at the same time, there's a little playful side to you as well, whether it's on, I'm not sure if it's on Instagram or on your website, where you have your No series, where you talk about bogus things, right? I'm describing it, and you can't really describe it. It's just you have to see it. As a physician, what are your recommendations for physicians in terms of how to get involved in social media in a professional way, and yet at the same time in a way that sort of lets you express yourself in a way of who you are as well? Because the reality is that is the means of communication that we have. Nobody goes to see people give talks at seminars nowadays. Nobody's watching the TV for these kind of talks at the local access channels. It's really social media. How did you get involved in that? What are your suggestions to other physicians who are maybe a little bit resistant to that? What's the way forward?
It's been kind of a staged process for me. I was in college at an interesting time. My freshman year in college is when the very first Apple computer came out. And of course, with my curious mind, I had like 10 of them. I had all my dorm mates buy one up so I could take them apart and see how they work. So and obviously that's pre-internet. So branching from there with that level of computers into using the internet for production, started in fellowship to record video and record surgery. And when I left my fellowship, I continued to do that. So I literally have been recording surgery for 20 years, everything I've ever done. So we started with VHS tapes, transitioned to CDs, and now we do everything on digitally on YouTube or one of those formats. And the staged process for me was initially that was shared and designed to be shared with two categories. One was for the patient, and the other was for my colleagues. And with LinkedIn and ViewMedi and some of those platforms. And then somewhere about 8-9 years ago, in our tracking of patients and how they found me, it became pretty obvious that patients were searching for me. They're not for me personally, but they were searching for doctors. They weren't getting a referral from their primary care doctor anymore. That all changed. At the beginning of my practice, half of my new patients came from referrals. That changed. And now more than half my patients come from looking on the internet or searching for Regenerative Medicine Dallas, or searching for Dallas PRP, or searching for shoulder surgeon Dallas. But whatever it is, they're on the internet. And social media is how they communicate. It's the way people communicate now, whether it's Facebook, Instagram, Twitter, those are the big ones. I use LinkedIn on a much more professional level, as you know. I had to become interested. I had to have a Facebook page. I had to have a Twitter account. And at the beginning, frankly, I wasn't really good at it because I didn't know much about it. And time is an issue. We're busy, and to come home and have an extra hour a day to post something informative or funny or thoughtful takes time. And so I found a company and a woman who's amazing, who that's her business. And what's really helped me is being with a boutique type of firm, where what she can do is say, okay, how do you want to market yourself? And after a couple meetings, she said, okay, look, here's what I got. You love surgery, you love regenerative medicine, you like to have fun. She sat in my office and saw me talk to patients multiple times and said, you have a good time with your patients. Everyone leaves. You guys are light. You guys are not serious. You're not patronizing. You don't tell them what to do. And she said, we want to market that. And so that's why you see the No series, because people will come in and ask us questions about, well, I just went to a seminar and they're going to sell me umbilical cord blood as a stem cell injection. And so I thought, wouldn't it be cool to just take all those frequently asked questions, since the answer is the same for so many of them, and just say no. And that's what we do. And so we call it, KNOW. You need to know. You need to know better. So, but social media is the way people talk. And the coming trend for us now that I'm working on actively is with Google and Alexa and Siri. Because now people are sitting in their living room and saying, Alexa, find me a regenerative medicine doctor in Dallas. And you have the much longer voice search, and that's a different algorithm. And there's my Alexa just triggered, by the way. But that's a different algorithm that we have to be ready to pivot to, because now people are going to be in their cars. Everything's connected to the Amazon world or Facebook, and being able to do those voice searches is going to even overtake just typing into a Google, Bing, or Yahoo search, in my opinion. That's what I've seen and what I firmly believe. So, free tip maybe from our podcast is get your social media person in tune with your practice, and in tune with what you love to do, but also make sure that you're ready for the next stage. I'm always thinking about, okay, what's going to be happening next year, the year after, and it really looks like, I look around my house and we've got 7 or 8 Alexas of various flavors, and I ask Alexa all sorts of stuff. You can ask whatever you want. She never gets mad. So I think that's where we're going. So soon it'll be, Alexa, post this on LinkedIn, and be able to do it directly just from talking.
Right. Yeah. And for really all service and professionals going forward, in the next couple of years, if Alexa does not love you, you're in trouble. Like, Alexa really has to know who you are. Okay. So just sort of getting toward the end of our time, give me a sense for what are you most excited about, the future, what's coming in terms of regenerative medicine. What are you really most sort of juiced up about?
Oh gosh, I think that my only regret, if I started it that way, would be that we don't have more ability to do data in my situation, in my clinic, because when I go to these meetings now, I'm excited. Having done shoulder surgery for a long time, there's some things every year that come out in the surgical world that excite me. But regenerative medicine, every meeting, there's something that at least is thought provoking. And so I really enjoy that. That's one of the reasons why I wanted to be involved in the journal, is to see some of that stuff, hot off the press, if you will. I do most of my procedures in office, as you know, and I think there's going to be more and more of us that are moving things out of surgery and into the office as surgeons. So today's a good example. A couple ORs down, there were people getting what was at least posted as partial meniscectomy, and with what I can't help but think, gosh, I wonder if they did PRP first. I wonder if they did BMAC first. Just seeing the growth of the industry is, I think, what's most exciting. If there's going to be new orthobiologics that come out, then I think that'll push the needle a little bit also. But right now, I think with where we are with BMAC and PRP, I think there's plenty of work to be done. And I'm just excited to see where we all take it.
Outstanding. Well, listen, I appreciate your time. For any of our viewers or listeners, if they'd like to learn more about you and your practice, they can read more at Dallas PRP and Stem Cell Institute. That lists all of your social channels as well. And thank you for your time. And I'm excited about the future because of guys like you who are leading the way. And I think you do it the right way. And I think you're a really great role model for anyone who has an interest in this field professionally, and definitely for orthopedic surgeons who want to see how to evolve to the next thing like you've been able to do again and again.
That's really kind. I appreciate it. Look forward to seeing you soon.
Great. Thank you. Bye-bye.